even better. So just the indication sometimes is not there for a screw-retained hybrid. And that's kind of, Dr. Makrauer and me, we came together and we said, well, you know what, let's just walk through two different alternatives. And that's kind of what we want to do today. So I want to introduce Dr. Makrauer, Dr. Zola Makrauer, a very good friend of mine. And we go back a few years now. We met actually at a speaker series and a course where we both attended DevRite. And so we both went together there. And since then, we are good friends. We work a little bit together. And now it came up to, he called me last week and said, hey, Alex, let's do something together, something fun. And I said, this is an awesome idea because I love anyway, do technician, clinician lectures and education because we have to work as a team. And so it all came up there basically. So I want to introduce Dr. Makrauer now. Dr. Makrauer, he works in his full-time practice in Huntington Valley, Pennsylvania, and he speaks national and international on practice management and implant restorative dentistry. Dr. Makrauer also is a part-time clinical instructor at the Kronberg School of Dentistry, and he's a Straumann faculty lecturer. Additionally, he has been published in a national peer-reviewed dental journal, the Compendium. I think everybody knows the Compendium, and has also been published in Stargates. Dr. Makrauer maintains memberships with numerous dental organizations and is the fellow of the International Team of Implantology, the ITI of Basel, Switzerland, and a master of the Academy of General Dentistry. Dr. Makrauer is also the past president of the Eastern Dental Society. So thank you, Zola. I should say Zola to you today. We're good friends. So thank you for joining me today. That is just fantastic. I'm going to introduce the topic a little bit and then give you the word over and stop sharing. You can just take over. So when we talk about full arch, we usually have in mind that is something complex, right? So last week I talked a little bit of complex reconstructions and I was questioning what actually is complex. And we were going through different scenarios. Complex can be a veneer case. It can be a full mouth rehabilitation. It just can also be the single central. These are all complex restorations. When we talk about complex, usually I know we have that full arch restoration in mind. And then we see the aesthetic in mind and see, oh man, that looks good what we see here. We see beautiful teeth. We see a nice tooth display. We go through the aesthetic principles with the smile line, with the midline, incisal edge position. We see all this and be very happy up to that point. We see the total failure. And I showed this image last week. And then Dr. Makrauer gave me another slide, which is another bad day, right? So we just see poor planning and poor communication. And then we sometimes stuck. We said, damn it, what did we do? We should have done something different. We maybe should have planned differently or executed the final reconstructions differently to not see that aesthetic failure. So here, I'm now starting with Dr. Makrauer. Let me move my line very quick here. I will stop share and Zola, please take over.
All right, let me start sharing my screen. Here we go. All right, and let me minimize everybody. Okay. All right, so the idea here really, what I want to try to achieve is I want to take the mystery out of the MK1 and these different types of detachable full arch restorations. In my vocabulary, when I mention the word conventional hybrid, that's really a node bar that's wrapped with acrylic and denture teeth. So we're not, this particular case that I'm going to be presenting, the lower arch is going to be a conventional hybrid, but the upper arch is going to be different. And that's going to be an MK1. So that's really what I want to present now and just show you some of the steps that are necessary. And the bottom line here is that we're really doing a full denture that happens to be connected to implants. There's no magic or mystery with regard to these types of restorations. And most of the magic, actually, I rely on Alex for him to do that. But pretty much the steps are all the same for me with whatever type of restoration that I'm going to be doing. So this is Gerald, and Gerald just got done having a lower full denture fabricated that was not supported or connected to implants. And his fiance at the time has been a patient of mine for probably 30 years. So she asked me to do her a favor and see Gerald because she didn't like the fact that he took his full denture out, and she said that it actually reminded her of her father, and she didn't want that. And these guys, they were engaged to be married. So Gerald came in, and this, you can see the upper occlusal shot here, and this is the radiographic image, and you can see that he's got a lot of problems, a lot of gross decay. He's got periodontal disease, and I'm thinking in terms of actually having all these teeth removed and doing a full arch restorative for him. And the important part here is that the MK1, its advantages are is that it gives lip support. So for people who need to have that, which Gerald did not need to have that in this case, but many times we do these types of conventional hybrids and the patient's lip might look sunken in. In that case, we have to give support. So an MK1 can do that, and it also allows for good oral hygiene. And the issue for Gerald was the fact that his fiance wanted him to have good oral hygiene. So she sent him to my office to have something that is not removable. But then once she realized that periodontally, he would be more sound if he had something that he could clean on the upper jaw and have the hygiene be better, she decided that she was the one that was deciding, actually driving all of the treatment decisions. She felt as if that this would be a good restoration. So it was kind of like an oxymoron because he ended up with something that was removable. But the beauty of the MK1 is that when it's in place, it's very solid. It is a fairly rigid restoration, which we really like that. And this is a slide that was designed by one of my surgeons, Dr. Robert Levine. I think also Dr. Phil Fava is probably on the call today. And I think Phil is the one who actually did the implants on this case as well. But this flow chart is a very cool chart. And if you really want to have this flow chart, I'm happy to send it to you in the end. We can give you my contact information if you request it from me. I'm happy to send it. So Gerald started with a well-constructed denture, and we were actually able to take this well-constructed denture and actually convert it to his conventional hybrid, his temporary, that he's going to wear for 3 months. He had enough dental landmarks on the upper jaw that we were able to get good impressions in a bite relationship. So we're going to take him into an immediate conventional temporary hybrid at first. Now, we could have scanned the teeth and we could have sent it that way. I did this in an analog environment, but this could have easily been done in a digital environment as well. And this is another very cool slide. And if anybody wants this slide from me as well, this was designed by Brian Harris and Robert Levine. And you can see here that one of the most common mistakes is that we don't remove enough bone when these implants are placed. And if you take a look here, you need 10 to 12 millimeters of restorative space from the implant interface to where the occlusal contact will be on the interior teeth. If you're going to measure to the incisal edge, you might need as much as 17 or 18 millimeters, depending on the patient. But this is one of the reasons why the failure that we showed before is because there wasn't enough bone removed and the implants were not placed deep enough. And this is probably the most common mistake that's made when we're doing hybrid restorations today. So what we're going to do is we're going to jump through the surgery, and now this is Gerald's appearance with his temporary hybrid in place on the upper. This photo was taken right after I inserted it. This was not converted at the chair. Alex was converted this actually in Florida. So we did the surgery on a Monday, and I inserted this on a Wednesday. The patient was informed that he would be 2 nights without teeth. And here is then the radiographic image to verify that our temporary hybrid is seated properly. You can usually tell when you put these in. If you're doing it indirectly, there is always the risk that your impression was not accurate. So you might be in a position where you have to move a temporary cylinder out of place and re-index it. It doesn't happen very frequently for me, but you can tell when you put these in, if the small screw that you're tightening, and I only tighten these by hand, it needs to be a very passive screw, and it should be very, very loose, 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 and then tight. And if you know that it feels like that, you know that everything really fits properly. So at 3 months, we're going to let the patient sit, and then we're going to now move forward with making our final restoration. So this is where we're going to convert him from a fixed temporary hybrid to an MK1. Now, at this point, I always take photos, and many people don't have fancy photo cameras like I have, but everybody has cell phones. So the more information that you can give to Alex, the better it is for him, and you're going to get a better product back in the end. So pull out your camera and take some photos. See what the patient's smile line looks like. Take a photo of the patient's whole head and see what the midline looks like. If there's anything that needs to be changed from the temporary hybrid over to the MK1, we kind of want to translate that now to Alex. Also, if the patient's only doing one arch, you want to verify that your counter model is accurate that you have. You might want to take a new counter model, because there's been times where I've actually worked on the opposing arch during that 3 months, forgot about it, and then sent a counter model that was not accurate. I've made that mistake. So you always want to go back and actually verify your counter model. Then you're going to remove the immediate hybrid and seat the impression copings. You want to make sure that they're tight fitting. And sometimes I do radiographs, critical radiographs to verify their fit. And I'm going to use an open impression tray technique, and this is going to be in an analog environment. I do not believe that there are any scanners today that can accurately, on a regular basis, scan a full arch without any dental landmarks. So I always do these restorations in the second phase in an analog environment, and many times I take that final impression with a verification jig in place. And I'm going to show you a few different verification jigs. If I do it in place, I'm saving a visit, because I always can try in a verification jig afterward. But if I actually take the final impression with a jig in place, then I feel very confident that I'm going to have a very accurate impression. I put the jig in pieces, and then I lute it together with pattern resin, and then I use that for the final impression. Now, I can make this jig, or I can have Alex make this jig, either way, during the 3-month healing phase. Whether you do the initial surgery in a digital environment or an analog environment, both ways you can have a working model during that 3-month period. So you can actually create the verification jig and use that for your final impression. So here is how the tissue looks from healing after 3 months. And we could use this, which is the Straumann impression coping, or we could use this for the impression as well. And this is just the temporary coping that is part of the temporary the temporary hybrid the patient's wearing for 3 months. Either one will work as an impression coping. So here's an image of a verification jig that Alex fabricated for me. And you can see here that I actually combined them together. This went in pieces, and this is what the impression copings look like. And once it's together, then I'm going to flow material underneath here, and I'm going to do an open impression tray on top of it. So I use a putty wash for this. You can use any material that you like. I find putty wash works in my hands very well. This is a jig that we made on our own in our office. And you can see this was not done with impression copings, but this was done with the temporary cylinders. And that's the reason why we don't have a screw coming out of the top of the hole here. So what we have to do is find a way to block out the screw holes. So this also went in pieces, and you can see it's been joined together. But what I used here was actually a cotton applicator wood stick to just block out the holes. And we're going to leave that in place while we take the impression. This is another type of verification jig, and this one is made of plaster. And actually, I think this would probably be a what we use dye stone for. Am I right, Alex? This would be dye stone here?
Yeah, you use usually low expansion dye stone for the accuracy. And I prefer that method for accuracy wise, especially for zirconia restorations. Mm-hmm. Why? Because stone has a very similar personality to zirconia. What happens if it does it passively, it will break. Stone and zirconia. So that's the reason why I like this actually, to verify models for zirconia applications.
Yes, great. And you know what? I have experienced one other thing. Sometimes the stone doesn't break, but the patient might say to me, and I always try these in without any anesthesia, the patient might say to me, I feel pressure, I feel tightness. that
Mhm.
means that your jig is just a little bit off and it needs to be cut. And what I use to cut these is a Brasler diamond disc. I find that it cuts them very well. It's a little bit of an expensive disc, but there are certain implications. There's certain times when I really like to use it, and it's a great disc. So, and then I can combine this back together with pattern resin as well. So those are three different methods that you can use to use your verification jigs. This is a mirror tray. I rarely use a custom fabricated tray anymore. The mirror tray is made of plastic and there's a tight cellophane on top of it. And when you use putty wash, it's very easy to pop those screws through. So there's no trouble with finding the top of the screw, and you wait for the impression to set and then you can unscrew it and it's very easy to remove from the mouth. I also like this because there tends to be the flange tends to be long on many of the custom impression copings, so this tray is easy to modify with an acrylic burr. Whereas sometimes acrylic that's made in the laboratory is very hard to grind away and it takes a lot of time. Also, when I pull this impression out, I look to make sure that it's clean. I'm going to take college pliers and actually grip onto the screws and try to move it. I want to make sure there isn't any movement in here. And I'm fairly confident if there is no movement that this is going to be an accurate impression. So once I've got my impression, I have two choices here. I could go to a bite rim, or I could go to actually mounting models using the patient's temporary hybrids. And I think we're going to show you some of that. Alex is going to comment on that in a few minutes. But if we're going to have to use a bite rim, we then get the bite rim back from the laboratory, and there's only two screws here. And if you think about making dentures, there's many times bite rims are taken in and out of the mouth in order to get them in the correct form. So I don't really like doing this procedure, but sometimes we just have to do it. Sometimes I only use one screw instead of two. And sometimes I actually am able to get a warm knife in the patient's mouth so I don't have to take it in and out so many times. The SRA abutment is I'm not going to say it's a bad abutment, but it is fragile and there's tiny little screws that connects to them. So we have to be careful with that, and those screws are easy to lose. So this can be a little bit laborious to get a bite registration. When the patient comes in for the bite registration, the first thing we're going to do is have the patient in a upright position, just close his teeth together and relax his lips. And then I'm going to make some marks on the patient's face and I'm going to translate them into the tongue depressor there. And then I'm going to put that aside so that when I have my bite rims in the patient's mouth, I'm going to put this up and have the patient close on the bite rims and verify that I have not significantly changed the vertical dimension. So a neat little trick. And here it is with the bite rims in place. I like the incisal display right here on this photo. And you can see that I've tested it again to make sure that his vertical dimension is correct. And this is what I'm going to send back to Alex to mount things up. So Alex, this is a slide that you provided for me. Maybe you want to comment on this?
Yeah, so that's basically what I, as a laboratory, always prefer. That is mostly the most accurate bite registration we can get back to the laboratory. I usually can send my client an articulator that we're all speaking the same articulation language basically for the plates because they're all normed basically. And then you're able to chair side mount or articulate with the temporary, screw the temporary on the master cast and articulate the chair side. The advantage is we have 100% the same occlusion as we have in the mouth. And so that kind of translates to me very basically perfectly the occlusion. Another advantage is, and the patient can get that prototype or temporary right back after the verification jig is tried in. And you can actually, before, take that, if you have an intraoral scanner, you can actually, can you advance to the next slide, please, Zola? And you can actually just spray the prosthesis very quickly, scan spray, and scan it with your intraoral scanner on that master cast. So that gives me two informations. I have first the perfect articulated model together on both master cast and antagonist, or on both master casts if you work on a full mouth rehabilitation. But also I have the 100% scanned, adjusted, so occlusally adjusted and aesthetically adjusted temporary basically on the model scanned, and I just have to import that scan into my system, and I can work right with that. So I don't need an alternate impression of the temporary in the mouth. I have all the landmarks I already marked on my model to actually align that situation to my original master cast. I can merge them together digitally, and I can work with that. That usually saves us at least 1 or 2 appointments to go to the final restoration. I love that. And you go to the next slide, please. That kind of how it looks like. It's a different case. I just want to show you how it looks like. That blue greenish color scan basically is the merged scan to my brownish beige colored looking model, and that's merged together. And now you see here how I can start designing that final restoration from your scan, from your mounting chairs at end, from the master cast and getting back into the laboratory, because I still need them to assemble the restoration on them. Thank you.
Yeah, so I really do like that workflow. The one thing that can mess up that workflow that we have to be careful of is if there's anything in the temporary hybrid that we don't like, if it's the incisal edge position, the positioning of teeth, or the midline, we're taking a risk by jumping forward that way. So if there's a problem that the patient doesn't like or something we don't like, I go back to wax rims to start over so that I can translate the incisal edge position and the midline in the canine eminence. So it doesn't always work out that way. It's a very cool workflow and it can go very fast, but sometimes it doesn't work that way. So
Agreed.
and that's why in dentistry there's 10 different ways to get to the finish line, and they all work sometimes and they all don't work sometimes. So we have to be careful with that, but it is a good workflow. So once we then have taken our bite, then we're just going to then do our jaw relation records. We're going to actually evaluate the centric relation and the vertical dimension. We're going to test our S and F sounds. Remember, our S sound comes from the amount of thickness behind the incisal edges of our anterior teeth. The F sound comes from the incisal edge. And during an F sound, the central incisors should just slightly touch the top of the lower teeth. If the patient is having a difficult time with an F sound, then we should start looking at the length of our central incisors, and then we're going to record our bite registration. We're then going to remove the immediate, this is the checklist for our wax try-in. We're going to insert the wax try-in, and we're only going to use 2 cylinders to do this as well. We're going to evaluate the VDO and the centric relation, everything that you would do for a full denture. So there's nothing really different here other than the fact that we're doing dentures 101, but it happens to be connected to implants. So I let the laboratory worry about the implants. I know that if I've got a good impression, there's nothing magical about this. If there's something wrong with your wax try-in, then you want to start taking photos. Again, get your camera out, and whether it's on your phone or a fancy camera, it doesn't matter, and send those photos to Alex. And sometimes you might have to take teeth off in order to get a new bite registration. The other thing is don't get called away by your hygienist while you're trying a wax try-in, because when you come back, the wax will melt and the teeth will be in a different position. And I know that because I've done it. And sometimes you got to learn the hard way. So this is what the wax try-in looks like. And you can see here, there are only 2 screws. So here I'm going to do wax try-in 1, and then I'm going to do wax try-in 2. The reason for that is we want to make sure that the teeth are in the proper position before we're going to mill any bars. Once we verify the teeth are in the proper position, then we're going to do a second wax try-in, send it back to the laboratory, and then Alex will mill a bar, and he will also make a receiving bar on the inside. This one happens to be a high polymer. This is pectin, Alex. Am I correct?
Yeah, that's pectin. Uh-huh.
Yes.
Yes.
So, and then we can try this in again. So this is the milled bar, and this is where I call this a barrel attachment, and the barrel then slides horizontally through this little hole right here. And this is the underside of the milled bar. So we're going to just place this in and hand tighten the screws. And that's how it looks in the patient's mouth. And I'm going to take a look at the wax try-in and make sure that my incisal edge positions are good and the speech sounds right. Here is a retracted view. You can see I have my bite fairly shallow. I even like to do them more shallow than this. And I'm going to point out these are the little holes right here. This is where the key gets inserted to disengage this. I'm going to make these holes bigger. When I do the final restoration, the patient doesn't have a hard time finding it. The key is nothing more than a glorified paper clip that is bent to have a handle on it. So if the patient loses it, I just tell them to use a large paper clip. So on the delivery appointment, I'm going to remove the immediate hybrid. I'm going to seat the milled titanium bar. I'm going to tighten the screws by hand, alternating from one side to the next. I usually like to put the most anterior screw in first because it's the easiest one to get to. Once I've got one screw in, if it's seated properly, we're golden. Then I'm going to place the MK1 in and I'm going to evaluate the occlusion. Once the occlusion has been finalized, then I'm going to torque the screws to 35 Newton centimeters. I do not have to worry about any Teflon or covering the screws. I leave them all exposed. I'm going to instruct the patient on how to insert it. I don't do that. My assistant will do that with the patient and help them a few times. I find these are much easier to remove rather than a restoration such as a locator or an overlock. I find we have to spend much more time with our patients teaching them how to get them in and out. So this restoration is really easy for the patient to use. We're going to go through oral hygiene instructions, and a maintenance schedule is reinforced. Keep in mind, these patients are not our stellar patients. They have let their mouths fall apart. They've kind of destroyed what God gave them. So we have to retrain these patients to get onto a good maintenance schedule. So this is what the inside looks like, and you can see how nice and clean it is. And you want to make sure that there isn't any acrylic left in here because this attachment then will get kind of hung up when it moves. This is the lingual side of this restoration. Here you can see it on the mirror here as well, the lingual side. So when this gets put in, the patient will put it in and just take their thumb and push it towards the facial, and that will engage the attachment. Of course, if Alex is doing it, you never have to worry about having any acrylic left in here. But it's a good idea to always check it because you could have a frustrating day because of one little piece of acrylic. So you've got to check that to make sure that it's clean. Alex, you want to comment on this?
Yeah, I just put this slide in just as an information because many people are asking or wondering about why did he use that kind of polymer in there. This is a high performance polymer, and I'm getting a lot of questions sometimes. How do you make that? So that's basically, you see here a blank. It's milled out of a blank of high performance polymer. The advantage what I saw or what we realized over the years now to utilize that material, especially for these kind of oval frames, oval bars, is it's just very, very comfortable to wear for the patient. It's not as ripping metal on each other. It doesn't wear, which is fantastic on a high polished titanium bar. And it's just very light. And I have aesthetically, I don't have to use opaquer, so I don't have that gray shine from metal through the acrylic or through any other layering material. And so I have already a bony color, which is now very natural in that area of the mouth anyway. So we like to use that. I'm using it very, very successful, and I will show later on the case I'm showing as well will be a Pacton case, a high performance polymer. And yeah, so that's kind of the reason why I would like to show that. Just people asking a lot about that kind of material, how that is actually fabricated.
So this almost looks like that's the bar inside the pectin. Is that what you're showing us?
Yes. So I just want to show we mill this, and literally that bar fits right in after milling. So there's no adjustments necessary usually. They are really milled in a high accuracy milling and just dropping right in. And you see left and right on these little kind of spacers there. That's the spacer for the attachment.
I see. Yeah, because it almost looked like there was metal in there, but it's not. It's just the receiving pectin with the milled bar inside of it, so we can see how accurate it fits.
Yeah, exactly.
Okay. All right. And what are you showing us here?
Just the bar, and then basically the processed attachments into that oval frame on the right side. We can use composite bonding material, acrylic. We usually use acrylic because acrylic bonds very well to the polymer. Since acrylic is a polymer as well, monomer based, and that's actually a really nice bond to that material. So that's kind of usually what we utilize, and then we process.
Okay. All right. And on this slide, take note, these attachments are actually kind of in the premolar area, whereas on Gerald's case that I'm presenting, the attachments are a little bit further back on the bar. And sometimes he tells me that he feels a little bit of movement in the anterior. And on those kinds of cases, if you want, you can actually tap in a locator or an overlock abutment, and then this can actually snap into position on top of that as well. If the patient feels as if they need to have more security, although I tell patients, don't take your fingers and do this, and you'll never notice that it really has some movement.
Yeah, true.
So you can see on this bar, it's a little bit more posterior than the case that you were just showing us right here.
Yeah.
So unfortunately, we had these implants in this position, and there wasn't enough room to move it more towards the anterior. But I find if you have these attachments in the middle of the arch, you don't get that slight movement in the anterior segment. And here it is at the insert. This was July of 17. And you can see here, it's a very, very nice, smooth transition. This is where the patient pushes it from the lingual to the buccal, and the lower is just a conventional hybrid. I keep that fairly high water so a patient can clean under it. And this is a retracted anterior view. This is the lateral views, and you can see here I've made these keyholes a little bit bigger. I would just take an acrylic bar that is shaped like a Christmas tree, and that way the patient can get a paperclip key into that hole without needing a mirror to do it. And at first they do need a mirror, but when they come into the hygiene room and I come in and I see them take it in and out for me, it's really very easy to do. I'm just going to follow up with this patient, and the patient should sleep with the prosthesis in place. If the patient sleeps with the bar being exposed in their mouth, there's a possibility that they could grind on it, and then that will affect how the bar fits into the MK1. I also have the patient wear a night guard, and I have Alex make the night guard on the articulator. So there's very little adjusting. The night guard will fit very well, and the bite should be very level. I review and check the occlusion at my 1 week follow-up. I review the patient's oral hygiene schedule. I reinforce that schedule, and I tell them that if they don't stay on that schedule, their warranty is voided. And our team, we warrant things for 5 years, assuming that the patient stays on their 3-month warranty. And this is how Gerald started, and that is his finish. And
Great.
That's what I have, Alex.
Okay, I'll take over.
Okay, let me stop sharing my screen.
Yes.
There you go.
And I'll share my screen here. And I just lost my presentation.
And Alex, while you're getting your presentation set up, this is Danielle from Zahntechnique. Thank you, everybody, for joining us. I wanted to remind you, if there were any questions throughout the presentations, you can please just use the chat box and send your questions in the chat box. And at the end of the presentation, I will go through all of the questions with our presenters today. Thank you.
So my presentation just went down for whatever reason. 1 second, please. Just have to restart.
So well.
Huh?
We were doing so well.
I know, right? Didn't we talk about this today before we started?
We did. I shouldn't have said anything.
But I'm ready now. It's back up. All right. Sorry for that quick hiccup here. We are ready. Perfect. All righty. So cool. Right. Thank you, Zola. It was fantastic. That was really very interesting, I think, and gave a lot of kind of towards the MK1. I want to show you all a different alternative to the MK1. And the different alternative, basically, in my world, I'm from Germany, as many of you know, and I used to do, or still doing, a lot of telescopic restorations. The telescopes are also a great alternative for any kind of dental restoration, full arch, partials, etc., etc. We're doing all kind of fancy things with telescopes because they solve many, many problems. And the problem can be aesthetically, as we saw before, the case Dr. Makrauer was showing with not enough lip support. Also, it's a very nice restoration for supporting hygiene, yeah, and making things just much easier. So now I want to show you a case. I did, Dr. Fava did the surgery in this case here. And this whole case was planned. We did the surgical guides, a temporary, and so on, et cetera, et cetera. And you can tell this patient definitely has some problems. Hygiene, of course, is a problem with this patient. Aesthetics is definitely a problem. And he's very aesthetic conscious. So he came basically, hey, I want to look good again. So make me look good. And maintenance. Yeah. So back to the telescopes, we explained the patient the advantages of a telescope, and he came right back, I want that. Why? Because he said, hey, that's perfect. I'm not perfect with my hygiene, as you can tell. So I want to have something really makes me easy to maintain over the future, but still feels like teeth, feels like a fixed restoration. And that's like the MK1, also the telescope is ideal for that. So now for anybody who doesn't really know what a telescope is, very quick introduction to telescopes. Telescopes basically is a object with parallel walls. And that object with parallel walls is the carrier for a secondary object which fits right over that. So now, basically a primary crown and a secondary crown which goes over. So now in compared to, and I'm very picky with that, in compared to a conus looks pretty similar or can look pretty similar, but it's something completely different. The only similarity is it's a primary piece and the secondary piece fits over, but the functionality is different. I want to walk you through this very quick. You see here, basically the secondary piece of a telescope, you see the parallel walls. I consider a telescope, these walls, 0 degree parallel up to maybe 2 degree taper. That's still very, very parallel, and in my world works still as a telescope, especially when it's multiple of telescopes on one arch. A conus usually is 4 to maybe 7, 8 degrees tapered. That does not have any telescopic function anymore, and that's the difference. A telescope has no friction. A telescope actually works with adhesion. I call it adhesion fit. You remember the 2 glass plates with a drop of water in the middle and you put them together, you cannot pull them apart. That is basically what works on a telescope. We need some moist, some saliva in between, and the patient will not get it just out. It will not fall down. The patient has to wiggle it out. That's the functionality. On a conus, on the other side, we have friction. So what's the negative on friction? I will show you in a second. I will write it down. On a telescope, usually the advantages are very clear. And that's my experience over now 25 years dentistry I'm doing. We have a longevity of about 10 to 12 years at least, where we don't lose any stable fit. And I use on purpose the word stable fit because I don't want to use friction. And there is barely any other wording we can utilize to have something stable fitting on something, not falling out. So that's a stable fit over that many years. There's a passive fit. So we put it in, it just fits in there. There's no gouging, there's no wiggling. It just fits very, very strong. And on top of this, my workflow I'm following with Galvano, I'll show you in a second, is we're working in an accuracy about 2 to 4 micron. And we are in the digital world nowadays, we cannot achieve with any kind of CAD/CAM system an accuracy of 2 to 4 micron across the arch. That's the key. You achieve with that passive fit an accuracy between 2 to 4 micron across the whole arch with 4 to 6 to maybe 8 telescopes. And the maintenance is extremely low, especially in the restoration I'm going to show you today. On the other end, the conus, we have a longevity about 2 to 3 years, max. Why? Because it's friction fit. What happens when metal on metal rubs against each other, it will wear out pretty fast. And there are some companies out there that are pushing the conus technology a lot, or the conus product basically, and I do not like that, to be very clear, and I stand behind my words here. Why? Because it definitely wears both surfaces. And at some point over these next 2-3 years, the latest, we'll have either a complete loosening of the prosthesis, it will definitely fall out, it loses friction, or we have the prosthesis locking in, and literally you as a clinician have to cut it out of the mouth. So that's kind of my experience over the years with conus restorations somebody did, or some other clinicians and technicians or whoever fabricated these. They're basically programmed to fail. I always call it like that. So let's just start that was a quick introduction. I can talk for hours about that system or about telescopes. We don't have the time today, so I'm also happy to answer any questions later on, or you can email me or even call me later on, or over the days, weeks, we have time, right? I'm happy to talk to you about telescopes. That case started with Dr. Fava, and then we started the restorative work for the final, basically. And he was helping his restorative dentist through this whole workflow. So we were working all together in this case because the doctor was kind of younger and needed some support basically from the team. And that's kind of, I think, where we have to work anyway all together as a team. And that one comes down to successful and predictable treatment. So here now we see already, these are the scanned master casts. These are the scanned provisionals, or actually that's a wax setup we did in this case, just to kind of see where we are aesthetically, if the patient likes that. And I'm merging this to my scanned master casts, and that helps me now to design the primary telescopic crowns. You can see they're all lined up, all parallel to each other. That is very important for a passive fit. Now we see here, I remove the pre-op, and we see here all the telescopes lined up to each other. Important is that they are parallel to each other on each arch. They don't have to be parallel the upper to the lower. Yeah? So on each arch, they have to be individual parallel to each other. And after that process, we can actually mill them with our milling machine. I prefer to mill them in zirconia as long as they're nice and straight and not too angled. If the angle is larger than 15 degrees, I usually go to full titanium telescopic abutments, because the stress of that angle would be too hard for the zirconia, and at some point the zirconia would break. So I utilize here, in this case, zirconia on a vario base. It's a Straumann case, so these are basically cemented or bonded to vario bases. And you all see they're nice and shiny. So what I'm doing basically after milling in our milling machine, we bond them to the vario base, and I go back to a survey milling, to a hand milling, and mill them basically all to the polished state with very fine diamond mills and water cooling to get that to that state. That has to get done. You cannot utilize these telescopes out of the milling machine because they're just not polished enough. And I can also not hand polish it. That would cause inaccuracies. So I have to utilize the survey milling that I have full control over the parallelism of these telescopes, basically. After that step, we want to do the Galvano process. So for the Galvano process, you see here these milled telescopic abutments. I actually bond them with pattern resin to wires, and then I put them into a Galvano bath. Why? And sorry, let's go back very quick. You see there are silver painted, basically. The silver paint is a silver lacquer. That silver lacquer you also see on the side, it goes a little streak down to that wire, and that basically connects that wire to the surface of the telescope that allows in that Galvano bath to have the gold layered on that. And I can, in my Galvano machine, I can actually adjust the thickness of that gold skin. And you see here the Galvano process basically that is in the bath and rotates very fast with the magnet. And then the gold gets layered on that surface that you see here. And usually we work in a 2 to 3/10 thickness. So now we can lift this up, can clean up the gold, and we can go to the next step from here. This is all laboratory process. So at that point, you're totally out and you will be involved in the next step, basically. So here now, that gets rescanned with the gold on top. And now we can start designing actually the actual restoration, the actual prosthesis. Here in this case, as also on the MK1 Dr. Makrauer showed before, I decided for a high performance polymer material. So I designed a frame, almost looks like a copy mill bar, basically with individual preps. Why? The patient is very aesthetically conscious. So we actually fabricating here ceramic crowns on that polymer bar and finishing with composite. So let's see how that looks. So I have these individual preps and now individual crowns on these preparations. The advantage is if over time a crown would break for whatever reason, I easily can replace the crown because I still have that file. I just have to remill it, reglaze it, send it to Dr. Makrauer or to any other restorative dentist who works with that case. And that case can be cemented chair side, literally. The advantage is I don't have to get back the prosthesis to the lab and have to work on this for multiple days. I actually can leave it in the office, or you can have it with the patient, and when the crown comes, you just put the crown in. Basically, you can even temporize it. That's a big advantage in working that workflow. Another big advantage is I have no wear on these teeth because it's ceramic. Yeah, so there is no really wear like I would have on acrylic, or the risk on breaking acrylic off of the prosthesis. It doesn't happen here. So that's kind of the big advantage. So now here I see on the upper right corner the mill or the designed frame and the designed teeth, basically crowns. So this gets all milled. I have now the milled high performance polymer structure or bridge. Basically, I have my wax crowns. I'm milling them in wax and pressing lithium disilicate in this case. Also, lithium disilicate here is pretty good because it is very, very light. So the whole prosthesis has literally no weight. It's very, very light in your hand. And I have these gold copings. So now what's the next step? The next step is I have to deliver this to your office that you can pick up the gold copings in the mouth. That is so important because that allows to be for the prosthesis to be absolutely passive. Intraoral pickup, so you will screw in the abutments. I will give you a seating check for that. And then you basically put the gold copings on the abutments. You try in the prosthesis, make sure it fits passively over. And then you basically fill up the prosthesis or the bar with a resin, with a GC-Link Force, Multilink, Reliax, Panavia, et cetera, et cetera. There are multiple out there, whatever you prefer usually to work with. And you see in the right upper corner now, the copings are picked up with the prosthesis. Don't put it back on the model because there might be differences between the mouth and the model. Just leave it as is and send it back to the laboratory. And we can then actually working on finishing the process. So that intraoral pickup is extremely important for 100% passive fit, especially in implants because implant doesn't move in the mouth over time. We then finish the case. We finish the crowns, finish the porcelain, basically layering composite for the gingiva, to make it nice and aesthetic. And also want to point out, I'm usually leaving the entire surface in the high performance polymer because it's just cleaner than composite. It's a very dense, very smooth, and very clean surface where nothing really sticks to it. So there's no plaque, there's no bacteria layering on that surface. So it'll be very clean. But I still have the possibility, or it still keeps me open for myself or for you to reline that material later on if we would have some recessions, some tissue, or just partially reline it with more composite if needed. Day of seating, the abutments getting screwed into the mouth, and the restoration can be seated successfully. On this case, we literally had minor occlusal adjustments. It was really dropping in like a charm. It's very nice because we followed the whole protocol from A to Z, very, very detailed. And we see here the patient will pronounce canines, but that's what he liked. So we kind of say, yeah, I like that. But overall, very, very happy patient and very successful treatment for him. You can see it's a younger patient. Yeah, so some people would say, why not screw retain? This is like a fixed restoration, don't forget. Yeah, it's nothing, it's not a denture. It's even porcelain teeth, basically, or ceramic teeth. So that definitely works like a fixed restoration with the advantage it is removable and we can have a better hygiene. Your hygienist will love it because they have such an easy hygiene appointment with these patients. So now you see, I showed you a very complex case in terms of materials and also in terms of upper, lower, and so on. I want to show you some other alternatives to that on telescopes. For example, what I think another strength of a telescopic restoration is we're able to combine implants and natural teeth. And nowadays, in that time we're living in now with pandemics and et cetera, maybe economic slowdowns a little bit, patients maybe don't have the funds to make a full mouth rehab with bone reduction and 12 implants or 6 implants on an arch and go to screw retained, the telescopic solution is definitely a very, very good possibility to still get this patient to a very nice restoration. Why? Because we still can keep healthy teeth in the mouth, which is fantastic. That's usually what we're trying to do. We're trying to keep healthy there where it is. We can add implants to the arch to have some more support, and we can fabricate a telescopic case, basically. Over time, if that patient would lose another tooth, we just fill the telescope. We just fill the telescope, and the restoration still works. We don't have to redo the whole restoration. Over time, if you would like to add on another telescope, we just add on another implant. Be adding on an implant with the new telescope. With an accurate impression and an accurate workflow, there is no problem why that should not be possible to add additional telescopes to an existing restoration. So what I want to stress on is we're able to actually nurture that restoration over the years with that patient without have to redo the whole restoration again or anyway. So that's kind of, I think, the key, what I love on that restoration. Then we can finish it like this, with or without flange, and we have a very clean and hygienic looking restoration. This case was also done with the polymer. You see, I like that material. I want to also show you an alternative where we have basically not in a vertical room, or where we want to work with denture teeth. That's a traditional overdenture, palate-free, of course. Here also full implant supported. A telescope case. You see the Galvano copings are on the model here, and I fabricated actually a chrome cobalt frame or bar fitting over this, just because we didn't have the space for a high performance polymer. Yeah, so we need a little bit more space for that. So that fits perfectly over, and the same process is following now. Yeah, so we get out to the doctor, to you guys, and you make a intraoral pickup of these copings, and it will be sent back to the laboratory, and we basically can make the setup on the case for another try maybe, or can finish it. It depends what workflow we're able to go through. So that's kind of rounding up our telescopic discussion here. I'm happy to answer some questions in the chat. I just want to go to 2 slides with you guys, because regarding our momentary situation in the pandemic, in our business, in all of our businesses, and experiences we had now with offshore, et cetera, I just would like to remind you, check out our webpage with our Small Business Strong campaign we're doing. And I would like to just kind of listen to this very quick. It's Danielle, my wife. I want to also say thank you. She hosted us today. She makes everything possible that we come together here. And it's just great. And she's a great support for that. And that's her campaign she started. And just listen to her.
My name is Danielle Wuensche, and I'm a small business owner. I'm co-owner of Zahntechnique Dental Laboratory in Miami, Florida, where we're passionate about partnering with dentists to create smiles. When the economy restarts, I kindly ask for you to support your local dental practice who sends work to a business like mine. There are more than 30 million small businesses in the United States. Please keep small businesses in mind when you regain financial stability and begin to purchase products and services. I'm going to tag several small business owners. If you're tagged, please introduce yourself and your business to America and tag 3 more small business owners. If you're watching this video, please share it to support Small Business America. We can come together by supporting each other when the nation's economy restarts. Small Biz Strong.
Thank you so much. Yeah, so Small Biz Strong, just to remind you guys, that affects us all. Yeah, so we like to purchase at small businesses around local businesses, national businesses. We stay made in America. So that's, I think, is a very, very good message. I also would like to remind you on our YouTube channel, we are working right now on our latest video about zirconia restorations, or zirconia, the material in general. So I would love to see you guys signing up for subscribing to the channel, to see, we're trying to have on a regular basis, 2 times a month usually, a new video on there about clinical education, where technicians and clinicians come together, basically. Here I will say thank you for joining us today. I want to say thank you to Dr. Makrauer, thank you to Danielle, thank you for Straumann. They helped us today as well, and to make it all possible. And I am going to open now for questions. Please, Danielle, is there anything what we would like to discuss?
Well, we have a few questions from our participants, so I'm going to start with the first question. We have from Dr. Quincy Gibbs this is for Dr. Makrauer. Do your older patients have trouble pushing the plunger out with declining dexterity? So for the MK1 plunger.
Great question. And if you've done any locator cases, you would experience that even to a greater degree. I find that patients do very well with the MK1, and actually if they need a caregiver, it's easier for them to disengage the MK1 than it would be for a locator or Novalock type case. So I don't experience that nearly as much. Once the patient learns how to get it's not, when the patient puts the key in from the facial, it's not hard to push it through. It doesn't take a lot of force. So once that's disengaged, the unit will actually just basically fall off the bar. So good question, but I like it better than locators.
Okay, cool. Danielle, is there any more questions? Danielle?
I think Danielle left maybe.
Oh, then Danielle is muted.
I'm here. Sorry about that.
Okay, he was muted.
Next question we have, sorry about that, from Dr. Kirsten Bain. Question is, what is the minimum height and width of the zirconia abutment?
Okay, that's, I think, is related to the telescope. So the minimum height of a telescope in general, if it's abutment or tooth-borne telescope, should be roughly about 4 millimeters. That's kind of the rough height we need for the parallel walls, basically. That's very important to have that. If it's in some areas 3.5 millimeter and in some areas 4.5, so kind of it's in that average, that's fine, but that's kind of what I would usually say. The width, it can be as narrow as possible. The screw has to still fit through, right? So usually, I mean, I'm working with very small telescopes sometimes. I say if the width is, or the diameter of that zirconia abutment is roughly 3 millimeter plus, that would be ideal.
Excellent, thank you. Next question we have is, what do you use as a ceramic for your crowns?
That's also for me most likely. I use GC, so that's usually my person to go. I use the GC ZR FS for zirconia restorations. I use the GC Lisi for lithium disilicate restoration. That's kind of my ceramic to go. For PFM right now, we're using Noritake and EX3 basically, but we do not a lot of PFMs. We do PFMs, and I think PFM is a great restoration, but the market is most of the time asking for difference.
Excellent, thank you. A reminder as well, I know some people are logging off. Thank you for joining us. If you have a recommendation for what the topic should be for next week's webinar, please include it in the chat, or you can also send Alex or myself an email regarding what you'd like to see. I will also be sending a post-meeting survey, just finding out what was your reception to the presentation today, what can we do better. I'll also be asking in that evaluation if you have any additional topics. So if we don't get it in the chat, you can put it in the email evaluation as well. Next question we have from Dr. Knack. Alex, can an angle screw channel abutment be used for anterior implant angulation correction?
I assume that relates to the telescope as well. We don't actually need that because we have the telescopic abutment can have the screw hole wherever. It doesn't really matter. It basically, hey, Gary, thank you for joining. I just see you here. It can be wherever. It doesn't matter. Why? Because we have a prosthesis going on top, which hides all the screw holes. I hope that answers your question, Gary.
And Dr. Knack, I can unmute you.
Yeah, that would be great.
Okay, you're unmuted, Dr. Knack.
So I was only asking that question because I was thinking of a case done many, many moons ago that is over-engineered with 8 implants across the top, and the anteriors are pretty highly flared. And the patient's was taken out of his original hybrid and put into a provisional, and has been happy with it for years. But I know that something new is going to have to come down the road. And I just didn't know how far you could actually bring that screw back, well, in this case, it's coming to the facial without having to do some sort of adjustment to it.
So basically, if you say it's so flared out, the implants are flared most likely, right?
Yeah. So originally, when this was done, there wasn't even a SRA abutment made by Straumann at the time. So the original case was direct to the implants, and we had nothing but anterior shelled out denture teeth that fractured one after the next after the next. So I went back and redid the case as with SRA abutments and put him in a provisional just to be sure he wouldn't break, and he hasn't let me go any further because it's been completely stable for years. But I know that something is going to have to change at some point.
Yeah. So with the telescope, the great thing is we literally can have the screw axis hole, doesn't matter where they are, because we're correcting like an angled abutment, basically the angulation of that implant where we need it. If the flare is too much, like I say, if it's go over 12, 15 degrees, usually I'm going then back to titanium telescopic abutments just for stability, which is the same thing. It works very, very nice. So
as opposed to the zirconia you're talking about.
Yeah. Exactly.
Okay, thank you, Alex.
You're welcome, Gary.
Good to see you.
Same here, man.
Danielle, I think there's a question that we kind of jumped over from Dr. Kaufman. It's about whether or not an additional plunger can be placed in the anterior. I think that's more for Alex. I don't think that a plunger could be placed in the anterior, but I think that's why I had mentioned that you could go with a locator or a Novalock type. Alex, you want to comment?
Yeah, so it wouldn't make sense of plunger aesthetically because we would have a hole in the middle of the anterior somewhere. I agree with you, locator. They're sometimes tricky with the vertical space. What we do sometimes as well as a VKS ball attachment, either facially or buccally or lingually as an additional retention knob, basically what clicks in. That can be done. There are also some other kind of like C-tack attachments or so. We're actually kind of giving some friction to that restoration to the bar. So there are different possibilities to do that. I agree. A plunger, I would not do that. It would be over-engineered. I would just put the plunger in the sides and in the front if something necessary, something more like clicking in basically. VKS, ball attachment, or even a locator or Rhine attachment, they're a little bit smaller. Yeah, that's what I would recommend. Great. Any more questions?
We have one from Dr. Ginsberg.
Yes.
Let's see. So why are these cases called overdentures instead of hybrids? An overdenture would have a flange with a palate.
That is actually a fantastic question because I'm always fighting with myself how to call all these restorations. What is a hybrid? What is an overdenture? And I have always, and I really thank you, Dr. Ginsberg, for that question because I always have a problem naming what I showed, for example, with the crowns and composite and all the technology there, denture. Especially when you go to the patient, oh, Mrs. Smith, we just did an overdenture here. And they want to actually something fixed. So I agree with you. It's all what we do actually is a hybrid. And if we have a flange, a small flange, a big flange, no flange, whatever it is, partially palate or it doesn't matter, I all call it hybrids or some sort of bridges actually. Everything what we put in the mouth and connecting abutment size, is it implant abutment or even tooth abutments are bridges. So we can just call it bridge. We can call it a telescopic bridge. We can call it an MK1 bridge. We can call it whatever. I love this question because I have such a hard time to talk about overdentures. It's just in everybody's ear, and everybody usually knows what it is, and they say overdenture. So I like that question, but you're right with that, Dr. Ginsberg.
Alex, I can comment on this. If you notice, when I started today, I told everyone I call a conventional hybrid a milled bar wrapped in acrylic with denture teeth. Kind of set the tone, because every speaker that talks about these different types of restorations has their own terminology. It almost seems it's kind of like the Wild Wild West, where there's no one terminology that's been put out there that everyone's using. So I try, when I explain what I'm doing or I'm showing a case, I try to use the same terminology to keep it consistent. But that's a problem, because we could all be referring to the same thing, but use a different name.
Same thing. I'm from Germany. So I had half my dental life was in Germany, and Germany uses sometimes totally different terminologies for things. I came here to the States and was kind of, oh, what is that? So it's just how it is. And he just made a comment here: if you do a denture, the implants do not support the denture. Danielle is asking if he can speak. Can you unmute him, Dr. Ginsberg?
Oh, one moment, please. Okay. Dr. Ginsberg?
Yes. The reason I'm stating all this is because there's forces that are placed on implants. There's stability forces, support forces, and retention forces. Now, if you can decrease it just to retention forces, the implants will take a lot less stress and will last a lot longer. So all your work will mainly last probably 2 to 3 times longer than if the implants are actually supporting the prosthesis.
That's a good point. That's a good point. So this is how I break it out. There are prostheses that are implant retained, tissue supported. And then there are prostheses that are implant supported and implant retained. So when we're talking about, let's just call it a conventional hybrid. A conventional hybrid actually it has no tissue support whatsoever. It is only implant supported and retained. Now the MK1, that does sit on tissue. So that is going to get support from the bar, the implants, and the tissue. So it just depends on how you want to manage your restoration. The other thing is something that is tissue supported, it should be removable, easier to clean. Because if you've got a big cover on the tissue, then the patient can't clean under there. But it just depends on what restoration you're going to pick to do. And that's how it's described as to whether or not it's tissue supported or implant supported.
Yeah, great. Cool. Any more questions? I think we're good, right, Danielle?
Right. I'm just looking through the chat. I think we've covered all the questions that have been raised thus
Awesome.
far.
Alex and Danielle, thank you so much for having me on. I enjoyed it. I'm glad that I brought it up to you last week. But let's do something. I think we did pretty good.
So thank you, Zola. It was awesome. I really enjoyed that with you together, and we have to do it again.
Okay. And
awesome.
Everyone stay healthy and be safe. I'm going to say goodbye.
Yes, thank you everybody for joining, and I'm looking forward to, please let me know what you would like to hear about, and I'll try to make it happen. And we'll move on with our Client Connect over the weeks, even if we're back to work. Just have to find time for it, right? Thank you guys. Bye-bye.